here. Yeah, my slides are not as well constructed, or there's no cartoons and nothing funny in them, just text, so sorry. And I couldn't even find a Western Health kind of PowerPoint pro forma to use, so it's all a little bit amateurish compared to what came before. Look, I first came across hepatitis C treatment in 2009-ish, I think. And I wasn't prescribing, I was just really learning about it then. It was the first time I'd really encountered it. I was working at Innerspace then as part of the private healthcare team, but very, very closely with the primary NSP there. And the treatment was percolated interferon and ribavirin, and it was absolutely horrible treatment. It was a really special case that people had started. Used to see clients as a mental health nurse. They were a very, very small number went on treatment, and they were people who were, it was almost like a museum. It was so unusual to see people start treatment, let alone progress with it and finish it. And the workup was immense. People would see psychiatrists, they'd see the gastroenterologist who used to visit us, plus the head C nurse, and talk. Eventually they get the injections, which we keep for them, and take the tablets every day, and they got so sick. People often tended to disappear. Might see them, where we previously would see them daily, or at least a couple of times a week. It would be months would go by, and they'd come and they'd look terrible, thin and depressed, and just about coping. Relationships fell apart. It was a horrible, horrible treatment. And had also had friends who underwent it, and similar sort of stories, just awful. But most people, of course, couldn't get treatment at all. It would sometimes work, often worked, but often it didn't work. So not only was it horrible, but people would suffer, and they still have hepatitis C. I then went into, I guess it was a kind of hibernation from that sort of work for a few years. I was also working in the alcohol and drug sector, but a lot more with the alcohol side rather than the drug side, I suppose. Didn't see, wasn't so much a culprit, it's much more a tertiary-based job. And I merged, came back in 2015 back to the front line, I suppose, in Footscray, and it was a different world. People would take 1 or 2 tablets a day. There was no interferon anymore. The rapidity of change was still quite shocked by it. I haven't seen change in healthcare of such a magnitude in any other areas. Really, really, really dramatic, especially if you have that kind of time out like I had. I didn't see any gradation. I just saw the change. People could easily commence it. Anyone could do it. There were minimal adverse effects. All the other speakers have mentioned that the side effects are almost non-existent. We still have to talk about them as prescribers, but say, look, it's not. It's almost like talking to people who use alcohol about Campril or naltrexone. So look, you might get a bit of a stomach upset for a few days, but really, it's fine. Just see whether it works. And the chance of recovery is almost not 100% guaranteed, but not far off. So what's it like? I do both. Obviously, my main job is prescribing mostly methadone or Suboxone, and I do an awful lot of that. A massive amount of people come to see us in our service, and I really love it. But it's also, it's very different to hepatitis C treatment. I put that as addiction and disease, query. I think the discourse, the contentiousness around what addiction is it healthcare, is it social care, is it kind of all of these things, is a really difficult discussion, and one which I kind of have opinions on, but I don't think it's settled. Whereas I think it's clear hepatitis C is a disease, and it's not arguable, it's not constructed, it's just there's a virus, and medication will get rid of it. And it's as simple as that. Whereas when I prescribe methadone or Suboxone, it's a part of a whole range of other things that we do to help people. And I think they're brilliant drugs and they can really save people's lives, but it's not all there is. It doesn't have to be all there is in a couple of cases. It might be. In this, that's it. It's the easiest thing I do. So look, we've been through, in terms of how I actually do it as a prescriber, I've been through a little bit, so I suppose this is going over old ground again, but there's the Pretest Counseling, which is, talking to people just about what the test will mean, what it involves, what if we get a positive result, what will that be? We'll have a discussion about it, but the treatment is good, we'll treat you. I just say, look, we'll cure your disease. And I can say that confidently. A barrier which has been mentioned is a visitor pathology service. We'll hopefully be able to do that on site soon. I personally need to do a bit more pathology training because it's not something I've done a lot of. I'm not confident in taking blood, and especially with some of the, they're not so healthy veins that we see. It's difficult. It's a real skill, and I think a lot of people will be challenged with that. So, look, we recommend people go to a pathology provider a few doors down from us. They're used to seeing people with bad veins, with our client group. So they say, look, they're used to it, at least they're not going to judge you, they'll just take the blood. There are sometimes mistakes, which is a problem, usually filled in the wrong tube, so we have to send that for a second blood test, but most of the time things work perfectly. We also check liver, kidneys, hepatitis B, HIV, and then we get results a week or so later. The point of care stuff would be great, we haven't ever had access to that. But because we're also doing it largely in conjunction with other medication, people do come back and come back a week later. And we can do a quick calculation. People don't always need a fibro scan. We have this little kind of, it's an equation called an UPRI, which checks the likelihood of cirrhosis. If the number's low enough, we've got the gene type, we've got everything, we can just start treatment. If it's high, and it's only happened to me 3 out of about 25 cases, we'll send them for a fibro scan. And we've got one available to us in the hospital, which Rachel, who spoke here before, gives us quite easy access to. But it's not on site, it's a little bit difficult. Instead of worked out 15 cases, probably more than that, I referred 2 to a specialist service, out of those 15, and treated 13. The treatment, as I mentioned, is an adjunct to other treatment. We're providing usually, we're now doing a couple of people as well who are not on ORT anymore. They're just coming in for hepatitis C treatment. We have good relationships with someone where they feel very comfortable coming, and so we do that. But usually we have one appointment to start, a review, and a couple of appointments post-treatment. Like any other new area of practice, I was cautious at first. That's what was the colleague I work with. But it really does work, and it's really so easy compared to the other kinds of work we do. So I just thought I'd bring up some case studies to make it a little bit, I guess, grounded. So Ali, obviously all these are all quite anonymised. But it's first case I actually saw treated. I didn't treat him myself, but rather he was one of the clients I saw who I was treating with methadone. He's part of the Burnett study at the Burnett Institute. Very complex problems. Very likely to have quite a significant intellectual disability, I'm guessing, isn't it? I mean, I know him well, but he wouldn't be able to tolerate any kind of formal testing for that. So, based on clinical impressions, very limited capacity, very vulnerable, and he was provided with 1 month's medication as part of that study. I was very cautious about it. I was very worried. He's someone who spends most of his daytime standing around Footscray Moor, walking up and down, scoring. Personally, if I was doing that, I would have given him with his methadone. And I kind of was holding my breath every time I saw him, thinking, have you still got your tablets? You're taking them? And he had. I think that was luck more than anything else. But I'm not sure if that's the norm. But yeah, I was kind of a little bit perturbed by that. But he treated, he's cured, and he's still part of the study. So we're not actually involved in his treatment as such. We can't hear what's going on from him. So the first person I saw treated on site, again, these aren't people I treated, and it just shows kind of how it's crept from quite a specialist form of care into the mainstream. So this was treated by a psychiatrist who was on our staff, then she's now left. And then quite a discussion with the infectious disease service first, with the consultant hepatologist there. The person, and this is something we've seen time and time again, we've got very good relationships with most of our clients, but not all of them, and this was someone who we didn't. There's a very conflictual relationship with us. Kind of had to be seen in a special room and kind of in a bit more public space rather than the rooms we usually use. There was always a fear of aggression, and the pharmacotherapy didn't go smoothly, but the treatment for Hep C did. We had difficulty getting pathology done. That was always hard, but him actually taking the tablets and getting treatment was fine. It was probably the only thing that was fine, but nonetheless, he, you know, got good treatment, and we were able to see eventually when he got pathology on that the disease was cured. So it was difficult, but he, he's got his Bendigo now, so I don't know how he'll do, but he's okay. He was okay when we last saw him. And then this is the first person I treated. This is Thea. I've worked with her for a long time. She was actually the first patient I worked with when I first started working for the service. And we had a very, very strong relationship with her. So I work sometimes by myself and sometimes with our specialist pharmacotherapy program. We have 2 case managers who work very closely with some of the clients who really want case management or will benefit from case management. And we have a great relationship with her. We have a great relationship with her. Similar to what was described from the NSP, we're a treatment service, we're not an NSP, but nonetheless it's a place where I think we probably offer more than just a script. People come and they talk and they feel comfortable and they get treatment for things and they get psychological care and feel, I think they feel unjudged by our service. And like her life in general is very bleak, as it is for many, many people who we see, but we were able to treat her. And what was really, I think what biased down memory was that the treatment itself, as usual, went very smoothly, and she took her tablets, and I think they were dispensed with her methadone, so daily with a couple of takeaways a week. That things weren't good, there was a lot of problems with domestic violence and problems with the police, but because they look, despite all of these problems, one piece of good news is you've actually cured your disease. That's gone. And it's not gonna make everything else better, but it was a nice thing for her to hear. It was a nice thing to say, and amongst stuff which isn't very nice for her. And it's quite difficult to see some of the change coming elsewhere. This I think is it's the last case that I just wanted to bring up, and it shows some of the barriers we actually spoke about. This is an unsuccessful case so far. He's got a semi-detached relationship with us. He comes in for appointments, but it's kind of tenuous. So it feels like a tenuous treatment. He also goes to one of the very few pharmacies in the Footscray that sort of inner west area, which won't prescribe won't dispense hepatitis C medication, which is complex. I haven't come across that anywhere else, especially one that prescribes ORT, and it surprises me. He's also someone who's fortunately burnt his bridges with most other pharmacies, or all the other pharmacies in the area. So we've got a real problem there. There is another pharmacy who would give him his medication. He's not going. So what we're planning to do with this is introduce some case management, short-term case management, to help him get his medication, maybe even kind of go with him to the other pharmacy, get it, bring it back, figure out a way so at least the current pharmacy can give him the medication every day or every couple of days, and then see. But it's the willingness, I guess, isn't always there, and that's interesting because it's not something I've seen a lot of. And I think the slides from and the presentation from Burnett is interesting in that people do see barriers. There is an apathy around there, so it is exciting when we can do it, but it's also, I guess, it's a challenge. It's a surprise to me to see kind of the apathy around it sometimes, and finding ways to address that is really good. Yeah, we've got the client, we see him regularly. He's taking his methadone kind of. But the hepatitis C treatment seemed really, really hard to start, and I'm guessing that's maybe there's many other people like that, and I suppose that's where NSP, secondary NSPs in particular, can have that conversation with people to help to shift that along. I mean, we're always open for referrals. We're not doing much just straight Hep C at the moment, but it doesn't mean we can't. And it's easy work, so we're kind of happy to do it. The referrals and specialist care are very few. The two I remember, there's one man whose liver enzyme results suggested fibrosis, confirmed by FibroScan. He went to hepatology. And the other client was a bit more tricky and unusual. I don't know what's going to happen there. He's had a abscess and was treated, and so respiratory problems related to injecting. He's on an unusual anti-clotting agent, which has interactions with every single hepatitis C medication there is. and that's prescribed by respiratory. And when it gets to that level, and it needs that kind of level of specialist discussion, I can't do that. I don't think GPs can really do that either. So he's gone to specialist care. He'll get it, he'll get care, and he'll get treatment, but it's kind of that's the kind of situation where I think you really kind of need good, somewhere you can refer to have those kinds of discussions, make those decisions on treatments. And the interactions are actually hypothetical from what I've read. They probably won't happen, but I can't wear that risk and say, I'll prescribe this, it might go wrong. Let's just hope for the best. So generally it's really, when it goes well, it's really easy, there's no significant adverse events, it's very, very high cure rate, everyone who's taken the treatment has been cured. There was one case I didn't mention where someone actually did take it for, I think, 5 weeks, and then disappeared and had a test and they were cured. So that really does happen. Generally, when people are taking it, in the first case they show where someone was given a box of medication to have in their pocket for a month. Still, even then, they were adherent. They were adherent when they're hostile to everything else. Often, people feel better, relieved, and it's really nice to see the transformation. So, yeah, that's it.